So one of the treatments for bladder cancer is removal of the bladder. This video is going to help you prepare for that surgery and talk about recovery in the period after your surgery. The goals of this session are to assist you in preparing for surgery, to review what to expect after your surgery, to plan for your discharge home, and to assist you in preparing for a safe recovery when you're at home. Bladder cancer is the sixth most common cancer in Canada. It's more common in men than women, and smoking is the most common risk factor. Just a quick review of the urinary system before we proceed. Everybody is born with two kidneys. The kidneys filter the blood 24 hours a day to create urine. The urine drains from the kidneys through the ureters down into the bladder. Urine exits the body through the urethra. In surgery called radical cystectomy, which is the removal of the bladder and also the removal of some of the surrounding tissues and organs, in men the prostate gland and seminal vesicles are also removed. In women, the uterus, ovaries, and part of the vagina may be removed. For both men and women, nearby lymph nodes are also removed. After the bladder is removed, a new way is made for the urine to be collected from the kidneys and stored, and that's called a urinary diversion. You will have discussed urinary diversions with your urologist before you've made your actual decision and are having the surgery. There are three types of urinary diversion that we do. Number one is an ileal conduit. Number two, a continent reservoir pouch, and the third is a neobladder. I'm not going to go into detail about each of these options. Let's talk now about getting ready for surgery. One of the things that's most important is to maintain a healthy diet. It's important to try and follow low-fat, high-fiber, and also a high-protein diet before surgery to help in the healing post-operatively. Smoking is also to be avoided before surgery. If you are a smoker, if you can fast from smoking during this period, or even if you can stop smoking before this period, your recovery will be improved. We have people who can help you with this, and we can make referrals to smoking cessation programs within our region. If you don't have a plan, talk to us and we can set something up for you. The other thing before surgery to be aware of is exercise. This doesn't mean you need to go and join a gym, but really it's just trying to keep your body active. Again, it helps with recovery after surgery. You'll either be scheduled for or you have had a pre-admission appointment here at the hospital. During that visit, you would have possibly some blood work, urine tests, and perhaps a cardiogram as well. The people you'll see include the anesthesiologist in the pre-admission unit. This is not necessarily the anesthesiologist that will be doing your surgery. You'll also meet the nursing team there. They will give you a number of information booklets, two of which are regarding the diversion option that you have chosen, whether it be an ileal conduit or a neobladder. In order to prepare for surgery, we need to clean out your bowel. We now prevent you from putting food into your bowel so that there's less residue creation. So on the day before surgery, you're not to have any solid food at all. You can have clear fluids only, so liquids. Some of the examples are here: water, white Gatorade or other sports drinks, white grape juice, apple juice, white cranberry juice, and then clear tea or coffee. The other thing you can have is broth with no bits in it, so chicken or beef broth, and also Jell-O with no fruit. Just make sure you avoid any juices with pulp, such as orange juice, mango, pineapple, or grapefruit. The reason for this is to decrease the amount of residue in the bowel. So a reminder, no solid food in that day, so no breakfast, lunch, or supper. The night before your surgery, after midnight, it's important that you drink fluids in the morning, but just 2 cups up until 90 minutes before your arrival time. Most surgeries are scheduled at 8 o'clock in the morning, so the hospital will call you the night before and will expect you to arrive sometime between 6 and 6:30 in the morning. This means that you need to have those 2 cups of fluids up to 90 minutes before, so between 4:30 and 5 o'clock in the morning. And you can have the same fluids that you had the day before. Apple juice is a good suggestion. Don't drink any alcohol for a minimum of 24 hours before your surgery, as it can interfere with anesthesia. Don't chew any gum or suck on hard candy, because this can increase the gastric juices. In the pre-admission unit, your anesthesiologist, if you're taking medication, he or she will let you know what medications you need to take in the morning of your surgery. Can you please bring 2 packs of chewing gum to the hospital? This will be used in the post-operative period to help stimulate your bowel function. So now we're going to talk about after surgery. Your surgery will be 6 to 10 hours in length, and you've discussed this already with your urologist. All patients after surgery end up going to the PACU, the post-anesthetic care unit, also known as the recovery room. Many patients stay here overnight, and that is to monitor your progress and level of waking from your anesthetic. Usually there are no visitors allowed in the recovery room, but some exceptions can be made. If you'd like to visit, please check with the nurses in the recovery room. In the morning, the patient will be moved to 7 West, where the length of stay is approximately 7 to 10 days. Visiting hours in the hospital are now flexible. There's no defined times, but we ask that you respect the needs of the patient and the families, and also the other patients if there may be other patients in the room. We talked about the length of stay being 7 to 10 days, and one of the things that holds patients in the hospital is actually their bowels returning to normal functioning. After anesthetic, bowels can be sluggish, and in order to get bowels moving, people need to get up and get moving. The doctors and nurses will be checking your abdomen, listening for sounds, asking if you feel like you're passing gas. The nurses will be helping you get up out of bed and getting you walking in the hallways as soon as you're able. And one of the ways to be able to do this is to have adequate pain control. So that's why we talk about it here. It's really important that you have good control of your pain. It is personal. What patients need vary. The goals are at rest that you're comfortable enough to sleep. You may feel some discomfort, but you are able to rest. With activity, you may experience some discomfort and you know you have an incision, but you're able to participate. Your anesthesiologist in the pre-admission unit will have talked to you about an epidural. The epidural is a small tube in your spine through which fluid and analgesic medication will flow. You'll have this epidural for 2 to 3 days after surgery, where then it will be switched to an intravenous. Once you're eating and drinking well, then the intravenous will be moved and you'll get your pain medication by mouth. As mentioned earlier, this is personal. You really need to let the nurses and the doctors know how you're feeling so we can make sure that we're gauging your pain levels and that we're giving you enough medication. You will have control with the pump as to how much medication you receive, and there are lockout mechanisms to prevent you from receiving over what the physicians have ordered. On the wall in your rooms, you'll see this pain scale, and some of you may have seen it before, with 0 being no pain and 10 being the worst possible pain. Our goal is to get you down to about a level of 3 to 4. This way, you'll still be able to participate in your activities, but not be too drowsy to participate. Please make sure that you let your nurses and doctors know how you're feeling so that we can help you with this recovery. Another thing you're going to have are a couple of drains called Jackson-Pratt drains. And we tell you about this just in case you're moving around in the bed and you notice these drains there and wonder what they are. As you see on the screen, this is a small bulb that works by suction. The nurses will care for this, emptying it on a regular basis. It's normal to see pinkish blood-tinged fluid in that bulb, and most drains are removed before you go home. It depends on how much fluid is draining daily. If you do go home with a Jackson-Pratt drain in, home care nurses will come into your home to help out in the care of it. They will teach you, though, how to empty it on a regular basis. Stents are a small, hard plastic tube that's going to be inside your body after the surgery. They will be removed. They are temporary. They're used in order to ensure that urine flows properly. The stent starts in your kidney and ends either in your neobladder or else in your ileal conduit. It helps keep the junction open between the ureter and the conduit or the neobladder. As you see here, for a person with a stoma and an ileal conduit, these stents exit the body through that stoma. These stents will be removed after your discharge when you come back in for your post-op visit in Module I in the clinic setting. If these stents should happen to fall out while you're at home, they will be coiled inside your ostomy bag. Not to worry, just give us a call and let us know they've come out, but we do not put them back in. For patients with a neobladder, the stents will drain into the neobladder. They are sewn to the catheter. You're going to be going home with a catheter for 2 to 3 weeks from your surgery date, and these stents are sewn to the inside part of the catheter. When the urologist removes the catheter, the stents come out as well. And for both ileal conduit and neobladder patients, there are 2 stents, one into each kidney. Okay, let's talk about going home. This is a large surgery. Don't expect to feel 100% when you go home. And for most people, it takes a good 3 months to really get their strength and back to normal activity. For some people, it can take up to 6 months or more. And now's the time to really tap into your resources, friends and family, and making sure that you're supported through this whole time. One hint from other patients is to bring loose pants to wear home from the hospital. You really want to make sure that you're comfortable going home. All patients will be scheduled for a post-operative visit, usually 3 to 4 weeks from your surgery date. This will be set up in Module I with your urologist. And usually you will have a phone call booking this after you've been discharged. That visit will consist of a discussion of how the surgery went, how you're recovering, and also your pathology results. Decisions will be made regarding the next steps and your plan of care. Future plans will be made for ongoing follow-up with your urologist, blood work, and possible imaging. And this also may include a referral to an oncologist. Activity at home. When you leave the hospital, you'll be able to be walking in the hallways and you'll be able to climb stairs. It's important to keep up with that walking when you go home. Getting outside, walking one driveway, and then the next day walking another driveway, trying to increase the amount of walking you're doing each day. It's important because you've got a midline abdominal incision to have no lifting. So lifting no more than 10 pounds for 6 to 8 weeks from your surgery. For driving, you need to have had your first post-operative visit with your urologist, where you can discuss returning to driving. It's especially important for neobladder patients not to be driving while you still have a catheter in. For nutrition, there's no specific diet that you need to follow after having had your bladder removed. We suggest you start with 3 small meals and snacks daily until your appetite is back. Some people find that cold food is more palatable than hot food, and especially if you really have a reduced appetite, it's important to get protein-rich foods. For example, you might want to try protein powders in a yogurt shake if you're really not feeling like eating a full meal. It's very important to drink at least 2 to 3 liters of fluid daily, and we'll talk more about that for our neobladder patients later. It's also important to avoid constipation as you have a number of incisions, and we want to make sure that there's no pressure on those incisions post-operatively. For your incision, if your incision is well healed, then you'll be able to shower when you're at home. When you are showering, just make sure that you keep the area clean with mild soapy water and rinse well and pat dry. Don't rub the areas, and don't use any creams or lotions around that area. You will still want to wear non-restrictive clothing as the area will remain tender for a while. All patients will meet with an intrastomal therapist in advance of your surgery. And an intrastomal therapist is a nurse who's specially trained in the care of stomas and ileoconduits. You will meet with her because she's going to mark the spot on your abdomen where it's best to place that stoma. She's also going to visit you on the ward after surgery before you go home. For neobladder patients, you will have a stoma site marked as a fallback if the urologist is not able to create the neobladder during your surgery. For patients with a stoma, you must be able to empty and rinse and close the pouch before going home. The nurses on the inpatient unit will provide you with support and education on how to care for your ostomy. They'll also give you a night drainage bag, which means that you'll be able to attach that to the pouch and not have to get up during the night to empty the pouch. You'll be provided with appliances to go home with, and the home care nurses will come into your home and do your teaching. They'll support you and help you with the appropriate supplies, but they will not come in forever. This is something that you will be taught to provide care for, and it will become part of your daily routine. When patients go home, there's often concern about what do you do if something goes wrong? When do you call somebody? So the next 3 slides are going to give you information about various symptoms you may experience and what to do about them. This first slide is talking about normal symptoms. These are all symptoms that people can experience after any type of surgery. So some discomfort or bloating in your abdominal area, a bit of redness along the incision. It's normal to have a small amount of drainage from your incision. Most people feel tired after surgery. You may want to schedule small exercise and rest periods in your day. A change in bowel habits also can happen. This next slide is showing scenarios when you need to go to the hospital. These abnormal signs, you need to go to the emergency department. If you experience lower leg swelling, pain, or redness, this could be a possible blood clot. If you have chest pain or difficulty breathing, again, could be a clot in your lung, could be pneumonia, could be cardiac issues. If you have increased pain not relieved by pain medication, you should come into the emergency department. Most people, when they go home, usually are taking perhaps an oral analgesic in the morning to help them start their day, and perhaps something again before they go to bed. If you find that suddenly something has changed and you're requiring more pain medication, then you need to come in so the doctors can determine what's causing that pain. Chills or fever, temperature greater than 38.5 can be flu, but it can also be a source of infection, and we need to rule that out. For our neobladder patients, if the catheter becomes dislodged, it's important to come into the hospital. We need to make sure that the urine is flowing properly and not backing up and filling the neobladder at this point in time. For these signs and symptoms, you can give us a call. We may be able to prevent you from having a visit to the emergency department. If you're unable to reach your doctor, please come into the emergency department. Incisional discomfort, the incision separating or opening a bit, redness around the incision. If you've got nausea, vomiting, diarrhea, or abdominal swelling or signs of flu, again, call us. If you've got any new or unexplained symptoms, give us a call. If you've got pain over your kidney or lower back, or your urine's got large blood clots or foul odor, this can be a urinary or kidney infection. It is normal to have mucus in your urine. For our neobladder patients, there can be issues with the catheter. If urine is leaking from around the catheter site, or if there's little or no drainage from your catheter into the collection bag for 2 or more hours, or if you've got pus around the catheter insertion site, or if the site is very irritated or swollen, red or tender, please give your urologist a call. Planning for your discharge. We mentioned earlier that the length of stay is an average of 7 to 10 days. If your family is visiting you in the hospital on a regular basis or friends, you may want to look at purchasing parking passes from our security department. You also need to think about who is going to pick you up, who's going to help you fill your prescriptions, and do you have coverage for your medication. Once you're at home, who's going to help you with daily tasks? Does a caregiver need to take time off work? When's the best time to take it? And do you need information about convalescence or perhaps respite care? You can be left alone after this kind of surgery at home. Someone does not need to be with you 24 hours a day, but it is important to have people around to help you with your care. This is just a list of some of the resources that are available for you for support, and especially the Ninon Bourque Resource Center in the Ottawa Hospital Cancer Center. You may have looked at some of these websites already. For patients who have ostomies, here are 3 websites for different companies that provide ostomy supplies. The Ostomy Association is a very good support group for people who have stomas, and they have a very good newsletter that you can find online, which is well worth looking at. That's the end of our presentation for preparing for surgery. Thank you very much for listening, and if you have any questions, please contact your urologist. For our neobladder patients, a short video on neobladder surgery will follow. For those patients who are having bladder removal and have chosen to have a neobladder, this next presentation will give you more information about the care of the neobladder. These 5 things are what we're going to be talking about in the next few minutes. Hydration, so fluid intake, care of your catheter, how to irrigate or flush your catheter, Kegel or pelvic floor exercises, and a new urinating action. When the urologist makes a neobladder, they create it out of about 60 centimeters of your small bowel. Our bowels consistently make mucus, and your new bladder is going to continue to make mucus because that piece of bowel is attached to its nerve and blood supply and will continue to function in that way. It's important to drink 2 to 3 liters or 8 to 12 cups of water or fluid every day to try and flush that mucus through. It is also important to drink this amount of fluid to help flush your kidneys and the rest of your urinary system. It helps prevent the catheter from becoming blocked with mucus. You'll see the mucus in your catheter drainage bag, and it looks like strands of white. There are varying amounts of mucus, as everybody is different. Some of you will have had catheters before. This is a small rubber tube that goes up through your urethra and into the bladder. It's got a balloon at the end that helps hold it in place. And your stents are actually sewn to that little black area at the tip of the catheter. And you can see it in the picture on the right-hand side. The catheter will be secured to your leg, and it's important not to pull on it because that balloon will then put pressure on the incisions in the neobladder itself. You want to make sure that the catheter bag remains below the level of your bladder, so when you're lying, place it on something beside you on the floor, whether it be on a garbage can or the side of a chair. You want to make sure you always wash your hands before and after caring for your catheter. The nurses on the inpatient unit will give you instructions on how to care for your catheter. You'll find the same instructions in the booklet you received in the pre-admission unit, the Radical Cystectomy Urinary Diversion Neobladder booklet. Your nurses on the floor will teach you how to irrigate your catheter, and it's important that you learn how to irrigate or flush this catheter for when you go home. This is to make sure that we prevent the mucus from sticking inside the catheter and blocking it. You'll be taught how to do this, and then at home you'll do it 4 to 5 times a day. If you don't get any fluid back after the injection of water, make sure you notify your urologist immediately. The instructions on how to do this are in your neobladder booklet, and as I mentioned, the nurses on the inpatient unit will ensure that you're comfortable in doing this before you go home. This is a list of supplies you're going to need in order to be able to do that irrigating. They can be purchased at medical supply stores such as Shoppers Home Health, Ontario Medical Supplies, and Canada Care Medical. You'll need catheter tip syringes and sterile water. You can make your own sterile water by boiling the tap water for 20 minutes and keeping it in a clean container. You'll need a box of 4x4 gauze. The hospital will give you a daytime leg bag and also a nighttime larger catheter drainage bag. You'll need some alcohol, some vinegar to rinse out the catheter bags, and you'll need a supply of incontinent products, urinary pads, pull-up underwear, or briefs. Make sure when you come for your post-operative visit in the clinic that you bring with you some pull-up underwear or briefs for when the catheter has been removed. In order to be discharged, you need to be able to flush your catheter every 6 to 8 hours before you go home, and you need to have the required supplies at home. Your urologist may have talked to you about Kegel exercises already, or you may have heard about Kegel exercises. These exercises are very important to help regain bladder control after your surgery. It's important to start them beforehand, then resume these exercises after your catheter is removed. If you exercise in the morning and mid-afternoon, you may be less tired, it might be easier to do, and you'll need cues to remind yourself to do these exercises. You need to be doing the exercises 5 times a day. In the next slides, we're going to explain how to do them. You need to stick with them. It's like going to a gym. It takes a few months to bulk up muscles. You'll see an improvement through the fact that you'll be able to control the urine in your bladder more efficiently. Just to show you where these muscles are, they're actually what you see in red. They go from the pubis bone in the front right to the coccyx at the back, in the male and female. They provide support to organs in the pelvis. They surround the urethra and they surround the rectum. So how to do a Kegel exercise. With your native bladder, there are 2 sphincter muscles, one internal at the neck of the bladder and one external surrounding the urethra. When the bladder is removed, you only have the one sphincter muscle left. That's the one surrounding the urethra at the bottom of this diagram. The purpose for doing the Kegel exercises is to support the pelvic floor, to strengthen the pelvic floor muscles, strengthen that one remaining sphincter muscle to help keep you dry. First of all, you need to isolate and find the right muscle. Sit down on the toilet and while urinating, stop the stream of urine. If you notice the muscle that you're using to stop that stream, that's the muscles of the pelvic floor. It's also the same muscle that you would squeeze to help you from passing gas. While you're doing this, make sure you're breathing normally and that your abdominal muscles are relaxed. And for men, if you're standing in front of a mirror and you squeeze your pelvic floor muscles, your penis will move and your testicles will rise. So now you know which muscle it is. You can actually do the exercise, but do not do it while you're sitting on the toilet. That was just to figure out which muscle it was. You need to find a comfortable position, either sitting or lying. If you're lying on your back, have your knees bent and feet on the floor. You'll squeeze that pelvic floor muscle and hold the contraction for 5 seconds, and then relax for 5 seconds. All through this, your abdomen should remain relaxed and you should be breathing normally. Try it 4 or 5 times in a row. For best results, you really need to make sure all your other muscles are relaxed and don't hold your breath. Once you've figured out how to do the contraction, you need to do contractions in a set of 10. So squeeze, hold for a count of 5, and then relax. Do that set of 10 4 to 5 times a day. So you're doing 40 to 50 actual squeezes in a day. If you want to set a reminder, you could do it when you get up in the morning, with meals, and then again in the evening. Some people do it when they're sitting in their car at a stop sign. This is an exercise you can be doing and nobody will know it. The hardest thing to do is to remember to do it. And this is a lifelong change. This is an exercise you need to be doing to keep those muscles of your pelvic floor well toned to help maintain continence. The last thing to talk about is how do you actually empty this new bladder once your catheter is removed. It's a very simple maneuver. When you empty your bowels, you increase the pressure in your abdomen and you strain, and that moves the stool along the bowel and out through your rectum and anus. Emptying your neobladder is similar, but very mild. So sit on a toilet, relax the muscles in your abdomen and your pelvic area. So make sure that everything is relaxed, maybe a couple of deep breaths just to relax. Place your hands on your abdomen and interlace your fingers and press in very gently and lean forward slightly. What you're doing is increasing the pressure in your abdomen, but to a very light degree. This will put pressure on your neobladder, and with your muscles relaxed, your neobladder will then empty. Again, this is all done very gently. At the beginning, when you're emptying your bladder, there will just be small dribbles. But as you go through your training, which you'll learn about at your post-operative visit, at the beginning you will have small amounts of urine coming out, but as you are able to extend the time period between going to the bathroom, you will have more urine. And As you empty your bladder, it'll feel like a trap door. The urine will fall out as opposed to having a steady stream. Part of that training will include increasing the time between the times you go to the bathroom to urinate by 10 to 20 minutes every week. Again, we'll talk about this in your postoperative visit. At nighttime, if you wish to remain dry, you may wake up naturally, but you may want to set your alarm clock to empty the bladder. The goal during the daytime is to hold your urine for 3 hours with good control. Never go more than 4 hours between urinations during the daytime. Some tips to help decrease the amount of leakage during the day and nighttime. During the daytime, you need to drink 2 to 3 liters of fluid, but you might want to slow that down in the evening. If you wish to remain dry at nighttime, you'll need to wake up during the night to urinate. So whether it's to wake up yourself or to set an alarm to wake you up through the night. At the beginning, you'll need to wear a pad or continence briefs at day and night. As you progress with your training, you may only need to wear a small security pad during the day for if you cough or sneeze, but you will need to continue to wear continence briefs at nighttime. One of the things we recommend for our patients is to get a medical alert bracelet. This will identify the fact you have a neobladder and will help healthcare professionals in the future if you are in an emergency situation. So finally, to finish up, these little hints, you really need to be patient with yourself and accept help from others. It takes 2 to 3 months to become comfortable with how the neobladder functions. And sometimes all you need to do is have a good sense of humor. Please make sure you ask questions if you're unsure. It may actually take 3 to 6 months to reach your new normal urinary pattern. And here I'd like to say thank you for listening. And if you have any questions or concerns, please contact your urologist.